So the objectives when it comes to cardiovascular stations, in particular about stable angina or acute coronary syndromes, um, our goal is that IMG should be able to recognize the clinical features of stable angina, perform ECG interpretation systematically, and this stratification through tools like TIMI, GRACE, or CCS, counsel the patient on the diagnosis, management, red flags that the patient should watch out for and come back if any of them are present. And you should be able to differentiate stable angina from acute coronary syndromes. First thing, what's stable angina? Chest discomfort or anginal equivalent symptoms such as shortness of breath. This is angina, but when do we say it's stable? If it occurs predictably on exerting patient or emotional stress, and the symptoms relieve in 5 to 10 minutes after resting or taking a nitroglyceride. The reason for this stable angina episodes to happen is myocardial ischemia, but in this case, the ischemia is time transient, and it happens because there is a fixed narrowing. There is no plaque rupture, there is no complete occlusion, there is no occlusion with myocardial injury. So the plaque that has happened in the coronary artery, it's fixed. Therefore, patient only gets chest pain when he exerts or she exerts himself or herself. It's not like coronary syndromes where plaque rupture could cause STEMI. There is no thrombosis ongoing of a blood vessel or a major thrombosis, and myocardial necrosis has not happened yet. This is stable angina, chest pain that starts on exertion or emotional stress or a heavy meal, etc. It is relieved by resting for 5 to 10 minutes or taking nitroglycerin. And the reason for the chest pain is ischemia, but without necrosis. Necrosis hasn't happened yet. Now, why does the chest pain happen? So when a person exerts themselves, the oxygen demand in the myocardial cells or the myocardium, it increases, but the supply is already diminished because of a stable plaque in the coronaries. Therefore, patients' oxygen demand is more than their supply, and patient starts feeling ischemic chest pain. Starts feeling chest pain. Now, the oxygen demand, it depends on the heart rate. If heart rate is high, the oxygen demand is high. Blood pressure, if blood pressure is high, the myocardial cells have to contract against pressure, and they may have tachycardia or they may experience ischemic changes or ischemia, tension in the myocardial wall, and the force of contractility. If you give patients something that medications that increase the force of contraction, we can induce an ischemia, and then if they have narrow blood vessels. Oxygen supply to the the myocardial cells, it is dependent on three things: coronary vessels dilation, the perfusion pressure or the pressure inside the coronary that should be high enough for the perfusion to happen, and diastolic filling time of the ventricles, because the right coronary artery that gets the supply during diastolic filling. Now, in angina, what happens is the tone is okay. It is lower or coronaries are dilated. Perfusion pressure is high enough, but there is a narrow plaque or the artery is narrowed enough. Therefore, the oxygen that is being supplied to the myocardium is lower than what it needs. Also, if there is a plaque, the vessel dilatation or the full lumen may not be present for oxygen, for blood flow to go through it. Therefore, when patient exerts themselves, their heart rate goes up, their blood pressure goes up, anything that strains the heart, they start feeling ischemic pain. And it is transient. Patient pain improves if they take nitroglycerin, which dilates blood vessels, or if they rest, which is going to bring the heart rate down or reduce the demand on the myocardial cells. Now, angina, typically it presents with retrosternal or substernal discomfort, and it is provoked by exertion or emotional stress, and it gets relieved by rest or taking nitroglycerin. What it feels like, quality of the pain is usually pressure, heaviness, tightness, something squeezing my heart. These are some of the descriptions that patient may give you. Radiation, jaw, neck, shoulders, left arm, it can happen because it's again myocardial ischemia and radiation is a possibility. Duration is usually minutes, not hours. If it has been ongoing for 40 minutes or an hour, it is not just stable angina, it is likely to be STEMI or NSTEMI. Common triggers, patients who have angina usually are the older population. So for them, common triggers could be walking, stairs, getting into cold weather, or emotional stress. Some of these can cause them to feel the pain of angina. Risk factors for angina or in cardiovascular diseases in general: high blood pressure, hypertension, diabetes, dyslipidemia. They promote atherosclerosis and plaque formation. Smoking, obesity, sedentary lifestyle. Sedentary lifestyle also causes cardiovascular deconditioning. So patient may not have as much fitness as they used to do, and they may not be able to stay symptom-free on the same activity that they could do at one time. Age and family history of premature coronary artery disease. If premature coronary artery disease is present in family, it increases the risk of patient getting heart disease or coronary artery disease themselves. Anginal equivalents. What are anginal equivalents? Things that we can consider as chest pain or angina if they happen in a patient who has risk factors. Dyspnea, shortness of breath, dyspnea, this can be considered as an anginal equivalent. Some patients may not have pain, they may have just dyspnea. Fatigue sometimes, nausea, epigastric discomfort. If these happen on exertion in a patient who has risk factors for cardiovascular disease, think of angina equivalents. These are equivalent to angina. Canadian Cardiac Society, they classify angina into 4 groups or classes. Class 1, it happens if patient has strenuous activity, they sprint or they swim or something similar to that. Class 2, slight limitation of ordinary activity. They can walk, they can work, but they may have trouble going upstairs or jogging, something similar to that. That's just moderate exertion. But class 3 angina patients, they are unable to do most tasks of daily living. They may not be able to walk a full block or 300 to 400 meters without feeling chest pain or discomfort or nausea or shortness of breath. Class 4 angina is angina with minimal activity. These patients may have chest pain on going from their bed to the washroom, which is the worst or the most severe case of angina. Now, physical exam. When you're doing physical exam for patients with angina, it's going to be normal. In most patients, they won't have any reproducible pain, they won't have any symptoms, they won't have any new murmurs. Some patients may have S4 or galopredon murmurs, heart failure signs. If they have developed heart failure or if they have heart failure with it, look for atherosclerosis signs, xanthelasma, or the presence of those plaques, arcus senilis in the eyes, carotid bruit. Listen to the carotid, see if there is any whooshing sound from the carotid, vital signs, peripheral pulses. These are some of the things that may be positive, but in most cases, patient will not have any physical findings if they just have stable angina. Now, initial investigations, 12 lead ECG would be normal at rest. and you do CBC, renal function, lipids, glucose, HbA1c, TSH. Anemias can worsen angina or worsen the ischemia that's happening, and can cause more thing. Renal function, sometimes patient with chronic kidney disease, they may have pulmonary edema or other risk factors. Lipids, dyslipidemia is a major risk factor for advancement of the plaque. So if patient has angina, we want to make sure their cholesterols are at the ideal goal. Glucose, diabetes is again a risk factor for promoting atherosclerosis. HbA1c and glucose, they would be done for screening for diabetes. Thyroid stimulating hormone, if patient has hyperthyroidism, they can get high output cardiac failure, or they can get chest pain because their heart rate is high and they have demand ischemia. Their coronaries are not wide enough to give them enough oxygen for their myocardium. Chest X-ray to see for pneumonias, other causes that can cause patient to have chest pain or angina-like symptoms. Echocardiogram, we do this, it's very important to do for left ventricular function and for valve disease. Now, if patient has, how we determine low diagnostic test approach, how are we going to do test for angina? If patient has low pretest probability, they are healthy, young, do not have cardiac risk factors, in that case, we would consider non-cardiac causes. Pneumonia could be a cause. Sometimes pneumonia may not have fever with it. It may have more chest pain than fever. Non-cardiac causes, musculoskeletal could be another cause. Intermediate probability, patients who have one or two risk factors for heart disease, then we do functional testing or CT coronary angiogram. High probability patients who are very likely to have coronary disease, we do coronary angiogram. Now, the test is based on symptoms and baseline ECG. For stable angina, how we determine if patient has stable angina, because patient baseline ECG is negative. If baseline ECG is negative, next step would be to do a stress test, either exercise stress test or pharmacological stress test. Stress test is going to induce the angina or the ischemia in the patient, and we would see changes on the EKG during a stress test, or patient will become symptomatic. In that case, we will stop the stress test right there and diagnose patient based on what we see. Now, let's talk about ECG interpretation, how we interpret ECG. If you're handed an ECG in your neck OSCE station, what are you going to look for? First thing, look at the rate. For rate, you can use multiple methods. The quickest way is to count the big squares between two RR and then divide 300 by that number. So if there are 3 big squares between RR, heart rate is 100. If there are 5, heart rate is 60. Anything between 3 and 5, this is normal heart rate. Anything above 5, if there are more than 5 squares in between 2 RR, think of bradycardia, then calculate more precisely by dividing this number. But for quick, at a glance, telling what the heart rate is, look if there are less than 3 squares between 2 QRSs or 2 RRs, or more than 3. If less than 3, tachycardia. If more than 5, likely bradycardia. Then you can do a detailed calculation based on how it is. Look at P waves. Is there a double notched P? Is the P R interval prolonged? Look at PR interval again. QRS duration. Is patient's QRS less than 120 milliseconds or more? If it is less than 120 millisecond and patient has tachycardia, then we say this is narrow complex tachycardia. It's likely a supraventricular. If more, in that case, we say patient's QRS is wide complex tachycardia is likely from ventricular origin. ST segment is very important for MIs. So that's why rate, rhythm, ST segment, and T waves. Another thing that you look for is ventricular hypertrophies. That would be the axis deviations. For a patient who is presenting with angina or chest pain, check that the lids are placed in the correct position and compare with patient's symptoms. If patient has chest pain and their ECG shows ST elevation and two related leads, it means that patient likely has patient has ST elevation myocardial infarction. Ischemia, infarction, conduction disease, arrhythmias, we are going to look at these. How do we do it? Let's go to the normal ECG. What the normal ECG shows first. Normal ECG, the heart rate should be between 60 and 100. PR interval is 200 milliseconds. And QRS duration is less than 120 milliseconds. ST segment should be near the isoelectric line. Let's say this is the ECG, this is P, and then QRS. This segment till T, this should be straight, similar to this one or this area. If it is tilted like this or gone like this, then it means there is changes in the ST segment. All right. Now, let's look at some pictures of ECGs. If you guys want to take screenshots, you're okay to do so. Remember, some of these pictures have a bit of mistakes, so don't take them on face value. Normal sinus rhythm, what does it look like? Every P is followed by a QRS segment and then by a T wave. It has P, QRS, and T. So all three are present, and patient's heart rate is between 60 and 100. The rhythm is regular. QRSs are happening at regular interval. If you look here, 4 squares, 4 squares, 4 squares, 4 squares, and so on. PR interval is 0.12. Look at this PR starting from here all the way to this place. Sorry. This place, this is less than 100 and less than 200 millisecond, or less than between 120 and less than 200 millisecond. Sorry. QRS is usually less than 120, but more than 100. And the axis normal is 0 to 90 degree. How do you determine axis? You look at the lead 1 and 3 or 2 and 3 and look at the S wave. See if the S is right reaches and left leaves. If both are positive, this is normal. If 3 is negative and 1 is positive, so the tips of these waves are leaving each other. They are going away from each other. Left leaves, this is left axis deviation. If 1 is negative and 3 is positive, then in that case, the 1 and 3, the tips are approaching each other, or right reaches. This is right axis deviation seen in some types of hypertrophies. Okay. Now, STEMI can present with several patterns. ST elevation and contiguous, or two leads that coincide with each other, and sometimes reciprocal changes, or a new left bundle branch block in specific arteries area. Interior STEMIs changes would likely be from V1 to V4. Inferior, it's going to be from lead 2, 3 AVF. Lateral, lead 1 AVL V5 to V6. Posterior infarct, sometimes they show ST depression in V1 to V3. If you see this, get a posterior EKG done. If you see inferior MI, get a posterior EKG done. Sometimes inferior is accompanied by posterior heart MI or posterior MI. Now let's see a few pictures of MIs, how they can present. Now interior wall MI, look at the ST segment. This is the isoelectric line, and the ST segment is here. So you can see the ST segment is quite elevated from the isoelectric line. And V1, V2, and in V3, again in V4, this patient has STEMI, or ST elevated myocardial infarction. Now let's go to the inferior MI. Here it's already marked. So in inferior MI, we said 2, 3, and where is AVF? These are the 3 leads that have ST elevation. Look at the isoelectric line and the ST segment. It's elevated, right? So this is ST elevated MI in leads 3, 2, 3, and AVF. This coincides with the inferior heart, or also sometimes it can be posterior MI, so we have to do a posterior EKG for this patient too. Now, posterior MI, if we look at the leads V1, 3, 2, 3, it has T wave inversion, and the R wave is tall. This means patient likely has posterior myocardial infarction. We need to get posterior leads. Now, key findings in posterior MI, tall waves in V1 to V3, ST depression in V1 to V3, upright T waves in V1 to V3. Upright would be kind of like this T waves that are tall. Reciprocal changes may be seen in anterior leads. Clinically, we need to correlate it clinically, usually caused by occlusion of right coronary or left circumflex. Consider recording posterior leads V8, V7, V8, V9. V7 posterior axillary line is where we place it. V8 we place it on mid-scapular line, and V9 we place it on the paraspinal area. This will give us an idea of posterior chamber of the heart or posterior area of the heart. Now, there is one phenomena that is this Whelan syndrome. It is also called a widowmaker. And if you see this pattern and these deep T waves in leads V2, 3, and it should be here 2, 4, this is a very dangerous pattern. It is the indication that proximal LAD or left anterior artery, descending artery is blocked, and these changes happen before the full occlusion happens. It means that there is a partial relief of the occlusion. Now the patient is going to go into a full-on arrest, not arrest, sorry, full-on MI, but the MI will be in proximal LAD distribution. It's going to be a really big or a massive MI. Therefore, we need to take precautions for this patient and manage them quickly to make sure they do not get the necrosis, or the necrosis does not happen. Otherwise, patient will have a very massive area of heart that is necrotic. NSTEMI or non-ST elevated MI, they usually come with ST segment depression and T wave inversion in the lateral leads or other leads also. So V5, look at V5, T wave is inverted. T wave is inverted. This is non-ST elevated MI. We will do troponin levels for patient and see how they are doing. Another interesting pattern that you would see on ECGs is atrial fibrillation. Atrial fibrillation, the QRSs will have a really awkward pattern. They will happen at irregular intervals. There will be no specific pattern for you to see. The rhythm will be irregular. P waves would be absent. RR intervals would be variable. They would change from one to another. And if patient is unstable in AFib, we do cardioversion. And if patient is stable, they need rate control with beta blockers, calcium channel blockers, and anticoagulation assessment. Anticoagulation assessment we do with CHADVASC. And we will discuss what it is when we are discussing AFib in details. Now, this is a sample ECG of how AFib may look. Irregular rhythm, no distinct P waves, irregular fibrillatory baseline, and there will be like these fine undulations. These are not like P waves, regular P waves, and then QRS complexes would be narrow. And if there is bundle branch block, then the QRS complexes could be slightly wide, but usually it's narrow complex. Look at the RR interval here. Between these two is 92 seconds. Between these two, it's 0.64 seconds. Here it is 1.28 seconds. So this is irregular rhythm on ECG seen in atrial fibrillations. Atrial fibrillation, if you look at the side note, it says it's the most common sustained arrhythmia. Sometimes it can sustain for more than 48 hours, and in that case, patient would need anticoagulation. It increases risk of stroke, heart failure, other complications. Rate control, rhythm control, and anticoagulation based on stroke risk. That's the treatment or the management guideline for atrial fibrillation. AV blocks, atrioventricular blocks. These are when the what's it called, the stimulation or the wave when it comes to AV node, and then it gets blocked at the AV node. That's what we call AV block. In first degree block, there is only PR prolongation. If we go back to this ECG, this is not stop right. This ECG, and here we look this P to R interval. Now this P to R interval, it's usually less than 200 milliseconds. In first degree heart block, this interval is prolonged. The R wave would be here instead of there. So it would be more than 200 milliseconds, but patient would not have dropped waves, drop beats. The patient's conduction would be happening, but it would just be slowed at the AV node. Now, for Mobitz type 1 or AV second degree block, then they are divided into two. Second degree type 1, which is Mobitz 1. This, the PR, let's say this is PR one wave, then this is the next PR. The PR keeps getting prolonged, and then there is a dropped QRS. Mobitz type 2, PR is fixed. It may be prolonged, but there will be a dropped QRS every now and then. Third degree block, it is usually a full block. In this case, there will be AV dissociation. P waves will not coincide with the QRS. Now, AV blocks, their management is simple. First degree, no treatment. Second degree type 1, usually no treatment unless the drop beats are significantly high. Second degree type 2 usually may require treatment. Type 3, or sorry, third degree requires treatment, and treatment is pacing. We can use transcutaneous, or we can use intra-aortic, intra-atrial. However, you want to do pacing for them, they may need pacing to keep their heart rate normal. Now, this is an EKG of a complete heart block or third degree block. If you look at the P waves, this is one P, this is another P, and then there is a QRS, but the P and QRS are very slightly close to each other, but they are not related. Now look at this P, this P, this P. These do not have any QRSs with them, so QRSs are dissociated from them. And then these are also dissociated. So there will be no clear association with QRS and P waves. Now, third degree block. So for ECG, the atrial rate is 60 to 100, ventricular rate between 20 to 40. Rhythm is regular. P waves regular marching through. They are present, but they are not associated with any QRSs. PR interval is not measurable because the QRS and P waves are not coinciding with each other. QRS narrow or wide depending on where the focus is. Cause is relationship between P and QRS. No relation, they are dissociated from each other. P wave happen independent of the QRS, they are not related to each other. Key points, P waves and QRSs occur independently, they do not follow each other. P waves march through the tracing at a faster rate than QRS. Ventricular rate is slow, rhythm is slow and regular, and findings are consistent with third degree block for this EKG. And here, if you look at the interpretation for this EKG, patient has third degree AV block with AV dissociation. Atrial activity is independent of ventricular activity, and slow, regular ventricular escape rhythm is present. Possible causes are degenerative conduction disease, ischemic heart disease, myocardial infarction, mitigation such as beta blockers, CCBs, digoxin, post-cardiac surgery, infiltrative diseases like sarcoidosis, congenital heart blocks. Now, In these cases, we are not supposed to give AV blockers like beta blockers, CCBs. We are going to make the uh, heart rate worse, or we are going to take patient into bradycardia. Now, how we are going to discuss STEMI pericarditis and how we use TIMI score, Gray score to uh, mark the patient for whether they need further treatment or they can be discharged home. So in pericarditis, patient has widespread concave ST elevation and PR depression. STEMI is usually regional. It goes into one artery's region. For example, lead 2, 3, 4, lead 2, 3 AVF, inferior MI. These are the uh, associations, the differences between STEMI and pericarditis. In pericarditis, pain is often loretic and changes with position. In both cases, use clinical context and serial ECGs. TIMI versus Gray score. Gray score is usually used in hospitals. It's more complicated, but it is more accurate. TIMI is simpler and binary, whether patient has high risk or low risk. This is how it's going to give you answer. GRACE is more accurate and weighted. GRACE is used when detailed risk estimation is needed. Both support clinical decision making in acute coronary syndrome. Now, TIMI risk score, patients age 65, 3 coronary artery disease, non-coronary artery disease, recent use of aspirin, recurrent anginas, ST deviation like depression or elevation, elevated biomarkers. These are all considered in scoring for TIMI. You're going to get, when you're in the hospital, you're going to use the EMR. It's going to predict the score for you. We'll just enter patient details. The higher the score, the greater the short-term risk.
Excuse me, please. Please,
yes.
what's TIMI?
Yes, this is TIMI.
Please, what is TIMI, the full?
Oh, it's a tool to estimate myocardial infarction risk.
Okay.
Risk of acute coronary syndrome in a patient who presents with chest pain to the hospital. If they are 65 years old, they are at a high risk. If they have 3 coronary artery disease risks, like diabetes, high blood pressure, dyslipidemia, if they have coronary artery disease, that's known. If they recently use aspirin, recurrent anginas, ST deviation, or like elevation or depression, elevated biomarkers. These are some of the things that TIMI score considers. You put it into a software or the EMR, and it gives you the risk score. If patient has 3 risk factors and they have chest pain, we consider them high risk patients. We do not send them to community for follow-up. Okay. Now, GRACE score, this is more comprehensive. It uses patient's age, their heart rate, blood pressure, creatinine, cardiac arrest history, ST deviation biomarkers, and CALIP class. And it provides more comprehensive details of long-term and patient dying in hospital in the same admission. It is useful to decide if you're going to do CABG, PCI, early invasive strategies. Now, CALIP's class is not discussed here, but it has 4 classes. One, STEMI, but no other symptoms. Second is STEMI with mild pulmonary edema. Third class is STEMI with severe pulmonary edema. And fourth class is STEMI with cardiogenic shock. Now, STEMI with cardiogenic shock, this has up to 80% mortality. If patient has it, 50 to 80% of these patients are going to die. STEMI, which has no other symptoms of heart failure or pulmonary edema, they have the lowest mortality. If they have pulmonary edema with STEMI, their mortality is still high. It's from 20 to 30%. Okay. Now, management of anginas or coronary artery disease. First thing would be lifestyle modification. Stop smoking, exercise regular, and consider cardiac rehab. Cardiac rehab, it focuses on improving patients' cardiovascular fitness. They give them exercises under supervision to do, and then once they're able to tolerate those exercises, they can add on to them. And then patient can, after the rehab is completed, they would be able to do their activity of daily living without any chest pain or shortness of breath. This is cardiac rehab. It helps a lot with patients who have angina or who had acute coronary syndrome, and now they are going to community after hospitalization. Heart healthy diet. low in salt, low in fat. This is something that is heart healthy diet, consider a heart healthy diet. Weight loss, control of blood pressure, control diabetes, and control lipid levels. These are some of the modifications that we will do with the lifestyle. Medical therapy, patient would be on aspirin or clopidogrel, antiplatelet therapy, high intensity statins, beta blocker as first line symptom control, nitrates for acute relief, like nitroglycerin you can give them, or sodium nitrate, calcium channel blockers if they need them, ACE inhibitor or ARB in patients who have a high risk of developing heart failure after the MI, or patients who have heart failure with the MI. Patient counseling. How are you going to counsel a patient who has angina or stable angina? Now, explain to the patient that their symptoms reflect that there is less oxygen delivered to the heart than it needs while they are exercising or exerting themselves. This is the mechanism behind their chest pain. You are going to tell them something like, you have stable angina, which is a condition in which patients feel chest pain when they exert themselves because their heart does not get enough blood or oxygen during exertion due to narrowed down blood vessels that carry oxygen to the heart. Ask them to be adherent to their medication, emphasize medication adherence, let them know to take their medication regularly, especially the beta blockers, etc., which are going to keep the heart rate low and the occurrence of symptoms unlikely. Even if they are asymptomatic, they need to take their medications and review correct nitroglycerin use. Ask patient to take one, repeat after 5 minutes, and if it doesn't get better, call emergency and take the third one out 10 minutes and lay down, wait for emergency services to get you. Discuss red flags and when to come to the emergency room or emergency care. Red flags for chest pains or stable angina patients, they include pain at rest or pain that continues for more than 15 minutes. Pain or the other symptoms like dyspnea, epigastric pain, etc., not relieved by nitroglycerin. Syncope, severe dyspnea, sweating, palpitations. If these are present, patient is unlikely to have a stable angina. It is likely worsening, or there is something going on, a plaque rupture or an acute MI. If the frequency of symptoms worsens, severity is worsening, or duration of pain is prolonging, they need to come back. They may qualify for getting coronary artery bypass or other treatment methods of invasive treatment options. Now, for angina differential diagnosis, they include acute coronary syndrome. In acute coronary syndrome, pain will not be relieved by rest. Patient's pain will be ongoing even on resting and taking nitroglycerin. Pericarditis, pain gets better on bending forward, may not have relation with exertion. Myocarditis, again, patient will have a viral prodrome or a viral URI or upper respiratory infection. Aortic stenosis, pain happens on exertion. Sorry, not pain. Patient feels lightheaded or goes into syncope on exertion. Vasospasms or transmetal angina can also present similar to regular angina. GERD or gastroesophageal reflux disease, it will cause sharp burning pain in the central chest area. Esophageal spasm, it can be hard to distinguish from MI because it's a muscle spasm, but it causes severe sharp pain. Pulmonary embolism, again, sharp pain, travel history, smoker, on OCPs, had surgery recently, risk factors plus sharp pain and difficulty taking a deep breath in. Pneumonias, fever, cough, these will be present. Pneumothorax, sudden severe pain onset with shortness of breath. It is concerning for pneumothorax. Costochondritis and anxiety can mimic chest pain that is angina-like. But in costochondritis, patient will have tenderness of the area or of the chest wall. And anxiety, patient will say that I keep getting these episodes and then they resolve by themselves. They will have a history are more similar to myocardial infarction, but they'll have a history of anxiety or other conditions similar to that. History and ECG, these are your friends. They will narrow the diagnosis for you. Key takeaways from the lecture or from today's class: stable angina, it is predictable, exertional, and relieved by rest or nitroglycerin. Resting ECG is probably going to be normal. Use these classes for severity. CCS classes, TIMI and GRACE score help in stratifying risk for someone presenting with chest pain. These are for acute coronary syndrome. We don't use them for angina. We use the CCS classes for angina. And counsel patient clearly on medication adherence and emergency symptoms. Make sure that they understand why they have to keep taking blood pressure medicine, statins, beta blockers, even though they don't have high cholesterol or their cholesterol on lab work shows normal. Okay, that's all that I have for today's lecture. We can